Today we're going to have a very interesting talk with a very interesting person. But before we talk about the topic that she is the best expert in, which is cancer and oncology, let me share with you how I met Dr. Beatrice Tiangco. And this is something that she probably does not even know. Dr. Beatrice Tiangco, when she was the president of the Philippine Society of Medical Oncology years ago, she wrote a letter to the PCP, the Philippine College of Physicians, about this practice of surgical oncologists or surgical surgeons, breast surgeons, giving chemotherapy. I was with the Philippine College of Physicians then, and at the same time, I was also the medical director of Bristol Myers Squibb, which at that time actually was the #1 oncology pharmaceutical company in the world. And I remember that I responded to Dr. Tiangco, but I don't recall what I wrote there, and I hope, I am sure that she also does not recall.
No, I don't.
And then fast forward, many times when we started meeting here at the Medical City, I was impressed with her because I realized that more than just expertise in medical oncology, she had a heart. And she was really active in this group, which I also joined initially, the participatory medicine group, which I dropped out of eventually because I could not attend to it so much, but which she persisted to be a member of, and which she actually had been an active participant in this group up to now. So when we started the Cancer Center at that point, years ago, she was just one of them who was there, a medical oncologist. And then it went through all different leaderships until in 2018, we came up with the Cardiovascular Institute this time. This was, of course, preceded by some leaders who were able to start the spade work on that. But we named this the Augusto P. Sarmiento Cancer Institute, after our chairman emeritus then, one of the original founders of the Medical City. And under the leadership of Trixie in 2018, a lot of things have happened that really augurs well, not only for the Cancer Institute, but also for the Medical City in terms of standing in the national sphere of healthcare. Before that, in 2014, during the time of Dr. Enrique Ona as the Department of Health, that was the time that a focus was made on how do we deal with the increasing epidemic of non-communicable diseases, one of which, of course, is cardiovascular disease and cancer. And it was around the time that she started toying with the idea of coming up with a cancer registry. And the cancer registry, through her own initiative, blossomed into what now has been actually adopted as the National Cancer Registry, and now involving many hospitals. From there, you can see that when we have more and more data, we are able to plan more and plan better. So that's precisely why when we established the Cancer Institute under Trixie, I was very, not only hopeful, but I was really optimistic that it was in good hands. So welcome, Dr. Trixie.
Thank you, Eugene, for your introduction.
That was a long one.
Yeah, I think it's going to get me into trouble at 2 points, but that's okay.
Okay. One of the things probably that we can talk a lot about other things because, you know, I think I have known you already much deeper than many, no? In terms of your values. I have told you that you are my conscience, right? When you feel that I am getting a little off, you remind me, no? As the CEO of the Medical City Hospital. Now, maybe we can start talking first with the Augusto P. Sarmiento Cancer Institute, or we call this APSI, in terms of in what way is APSI really different from the other cancer institutes in the Philippines or elsewhere?
Well, we do want to be different and known for how we are compassionate. In fact, that is written into our 10-year plan to become recognized internationally as a center of compassionate cancer care. As you have mentioned earlier, it's important for cancer patients, given the troubles that they're already in, things beyond their control, to realize that someone else is there for them, someone else understands to the extent possible what it is to have a life-threatening disease. And so that is, I think, what we at the Augusto P. Sarmiento Cancer Institute are really, really consciously trying to do for our patients. The other thing is, so aside from being patient-centered, it is being able to offer different points of view from the different specialties that take care of cancer, from surgeons to radiation oncologists, medical oncologists, palliative care, nutrition. We have, as you mentioned again, which will get me into trouble, long realized that it takes a village, that no single doctor can ever know what's best for a cancer patient, simply because it's too complex. And because there are different cancer patients that have different values. And so one may value aggressive treatment, and so therefore will want an aggressive doctor, or someone trained to do everything, to cut out every last bit of cancer. And there are others who really value quality of life more. And so we'll say, there's something to me that's worse than death, and that is living without a good quality of life. And please help me get a good quality of life. And so therefore, we call in our comfort care specialists. Sometimes they're known as palliative care, but that really sometimes has a negative connotation.
That's correct, yes.
So we avoid that because it sometimes hospice, palliative, and then so therefore death, which really is not. So now we are shifting to comfort, providers of comfort for cancer patients, but hey, we're willing to give it to anyone who needs it.
Apparently, the way you describe it now is that not only is it multi-specialty, there is so much participation from the patient and so much decision-making from the patient.
True, because you know, even here now in the different controversies going on around us and how to treat COVID, for example, I have to speak about it because that's what's probably in the minds of our listeners right now. Each patient is different. And so there's such a thing as personalized medicine. And personalized not just because you're different in terms of your genetics, which is how it started anyway, that term. Personalized medicine, you have your own biomarkers, you have your own biomarker profile, your own genomic profile, and then you're given the treatment that is appropriate for that particular profile.
Which the Institute actually provides.
Also.
Yes, that's right.
But the other thing that's personal goes deeper than that. We just don't look at the cancer itself and the details of that, but we look at the person and the details of that, which is even more important. So parang the personalized care that we give really also looks into the values, as I mentioned earlier. I'm redundant, I'm sorry, but really that's what we like to do because based on practice for like over 20 years now, and journeying with the patient from diagnosis to staging to treatment to cure, or not to cure, to life with cancer, even if you're stage 4, but good quality of life. And eventually maybe the natural course of the disease, despite the best treatment, is still death. After all, that's where we're all headed. We want to be very personal about it because certainly it's very personal to the patient.
That's correct. No, the challenge really is multi-specialists. They come from different training, different orientation. They also have different values.
True.
And now you gather them to handle this particular case, a burden, with the particular patient. And them learning how to look at it from the point of view of the patient. How easy or how difficult is that for you as the director of the institute?
Well, we work in teams, and so a patient comes in to join us at the APSI, usually through an attending physician. So whether it's a surgeon, rad onco, or med onco, that particular physician is the one who knows the patient best. And in general, it's this attending physician who knows the other doctors best. So, however he knows his patient as with these values, then it's up to that doctor to choose the doctors, the team with similar values.
Okay.
So, we do get to know each other. We meet every week. We have a general oncology conference. We have tumor boards, wherein we also put in our own style, our own personality in the treatment of cases that are presented.
I wonder whether that's always a peaceful way of discussing, or
not always. In general, it is.
It is.
But I want to think that if our oncologists here will speak up if they do not agree.
Okay.
Because it's useless. If everyone just agrees,
that's correct,
with one person, right? Or just because he's the attending and he's the one who calls you, then you have to agree. Otherwise, hindi ka natatawagin. No? So parang that's not what we want.
So, but over time, as the culture changes. No? In a way, they may come from different schools of thought and specialization, and of course, expertise. No? But when they come and this becomes a regular thing, and this is a regular thing in APSI, then I'm sure that even among the doctors themselves, there is a change in culture. Do you notice that?
There is, because I think it's because people learn to listen. The trainees especially. I think that's another value that we give, not just to the attending physicians, but also to the trainees who watch their role models, hopefully their role models.
Yes.
Listen. It's more important than showing everyone how much you know.
Okay.
It's showing your trainees that you're not always right.
Yeah.
That you're open to suggestions. And that the question always is, what is the best for the patient in front of you? So even if it's the same stage, the same primary site, same stage, but a different person, the recommendations should never be the same. And that clearly comes out.
That's out.
Usually it's because no money to pay.
That's
so how do we adjust our recommendation? That's more common, but others is also the uniqueness of each individual comes out, and we respond to that uniqueness.
You talked about role modeling, and I guess there is always a difference when you are the pioneer in the training program. I'm talking about Joseph Hilado, which I actually facilitated his training here. From now he's back in Iloilo. And I actually referred to him a patient. I was quite impressed, no? And he actually started talking and behaving like Beatrice Tiangco. So that just to tell you,
good or bad?
It is good because the kind of approach is something that quite impressed me, and I'm so happy because he's the one that's going to take care of the cancer program there. No? So now with that, we talk about after all the agreements and eventually kind of assimilation and integration and consolidation of all your discussions. No. Now you bring in the patient.
Yes.
What happens if the patient, up to what extent does the patient actually changes everything?
Oh, that's expected. In fact, that is already written into our template. So the first thing is there's a patient, goes to one attending and says, can you help me with this? And the attending says, yes, but let's meet with the other doctors. And so that is set by the cancer center. And then on that day, it's the doctors who meet first. And then it usually takes 30 minutes to an hour. And then we already, using the guidelines, say, and this is evidence-based, that this is the best recommendation that we can give for this particular patient. After that, we meet with the patient. And then introductions all around. And then we go over what we just discussed. So this is what you have, this is your stage, this is what's going to happen if we don't do anything. But we can still do better. We can change the natural course of your disease by intervening. And these are the different interventions. And among these different interventions, we think that this is what we should do. And then the patient will hopefully understands and is hopefully asks questions if not understood. And then he or she will say, what happens if I do this instead? First question is, how much will that cost?
Yes.
And then, how long will it take? What are the side effects? Will I be in pain? So, and then once asked and answered, what alternatives do I have? Some are not that savvy. Some will just say, okay.
Yeah.
Others will say, but I read, or my friend said, who's a doctor abroad, says that this is something that we should consider. What do you think about this?
Yeah.
Or they say, I read about this, or my neighbor had this. Why aren't you recommending it to me? And so further explanations.
Yes.
And then after that, the patient then with his values says, I don't want to have to come here every 2 weeks, or I don't want to spend too much, and I want this, it's more important for me to have a quality of life rather than surviving. You know, I'm ready to die.
Okay.
So that's when the patient's values come in. And certainly we listen to it, and that's what we follow. That's patient-participated treatment.
You know, Trixie, this is something that we're very, very proud of in APSI. The fact that, and it has been quite a journey in terms of getting these individual experts to really understand that no one expert can ever handle it alone, right? It took a while,
Yes.
I'm sure. This is not the case in many hospitals. I'm sure you have an experience of that. I really remember during the time that you were with PSMO, and I started to inquire about that case that you brought up. And so I actually asked a friend in that hospital, and up to what extent was this an issue? Apparently, it was a difficult thing to even start really giving life or even just a meat to this multidisciplinary approach to treatment. Up to now, I'm not so sure whether...
Well, I'm happy to inform you that it's much more common now to see a multidisciplinary approach.
Okay.
And maybe because many studies have proven that a multidisciplinary approach has better outcomes. And you remind me now, and thank you for reminding me, because that's one of the things that might get me into trouble.
No, it's okay.
As long ago,
No, yes,
when we were really concerned, not because, you know, I also honestly believe no one has the right to tell any other doctor what you can or cannot do, or to question the motives.
Okay.
Right? And many surgeons, if they give chemo, it's because kamag-anak nila. Or, you know, wala naman med-onco sa aking province. So what am I to do? Things like that.
Yes.
And that's perfectly acceptable. But sometimes kasi, if it's no longer in the best interest of the patient, and if there's no proper training, and the side effects won't be handled, you know, even if they're rare, what if it happens?
That's right. Yeah.
So that was the main impetus before.
The ability of one individual, not even a doctor, to realize that, you know, you belong to a community where you can really get a lot more in terms of strength, in terms of knowledge, if you share. That is something that I think you say that now things are much better now than before. I think the doctors are beginning to realize that they are really not next to God, right?
Yes. Fortunately, we're all maturing, and we've had this conversation before about the ego, about when you have meetings, you leave your ego at the door. Because that doesn't serve anyone.
That's right.
And because it's not about you. It's not about how expert you are, how much training you've had, whatever. So, yeah, I think globally, not just here, it requires maturity. And perhaps like your children, maybe one matures faster than the other. I guess it's the same with healthcare.
Yeah.
and with the practitioners.
But we still have work to do as far as health is concerned.
True.
Now, talking about, before I forget, this National Cancer Registry, which you are really very passionate about, and which has actually gained traction, but which can do a lot more, because a lot more hospitals should actually go into that. Maybe you can share with us your journey.
Okay, thank you again. Yeah. Because that's the second thing that get me into trouble. Let's not call it a National Cancer Registry.
Okay.
Even though it has hospitals in Luzon, Visayas, and Mindanao. But the word national is reserved for the Philippine Cancer Center's population-based cancer registry, which is taking off, and which is where my interview was previous. And so yeah, it's a hospital-based cancer registry system that came to fore when Dr. Ona, as you mentioned earlier, decided that all diseases should have all the top 10 killers of the country. Non-communicable diseases should have disease-based registries. And so that is the birth of an idea. Not only that, it was a clear need. It was a clear gap in care, in cancer care, that needed to be filled up. And how I lecture all my students and others who we invite to become a cancer care PH, that's what we call ourselves, a care PH site, is that you don't know, you cannot go to where you want to go if you don't know where you are. Like, for example, you enter a mall and you want to go to the Jollibee. And you see it in the map, Jollibee's here. But
it can be McDonald's, by the way. It can also be McDonald's. Okay.
It can be anything you want. But the point is, you have to know where you are to get where you want to go. And in our case, it is better healthcare for the Filipino cancer patients. That's our vision. And so every hospital needs to know where you are in terms of your cancer patients that you serve. And the country needs to know where they are in terms of cancer care before you can get to better healthcare for the Filipino cancer patients.
So we have focused more a lot on that. But I'd like now, being the director of APSI, and we would really position APSI as, in terms of the vision, to be really a leader there. Now, where are we now? We are actually more in the molecular, the genomics part. And you are also quite active in the technology part. And you have been actually not only a proponent, but actually a mover in Medical City as far as artificial intelligence is concerned. And I would like you to now share with us that kind of spectrum of interest that you have.
You know, Eugene, everything starts from something personal. Otherwise, you won't have the heart, right? And I love research, and I love two things: doing research because it will tell you what is true. That's the only way. That's the scientific method. Let's not go into the other ways of finding out what's true. But that's another long discussion. But scientifically, that's why I went into epidemiology and now into artificial intelligence. So that's
now, in between that, now, you also finished a course in health economics.
I did. I did. And it changed.
Multi-potentate.
And it changed a lot. It just articulated my personal, as I said, personal shift from being a lone wolf practitioner into a more community-based or a team-based, team practitioner as opposed to a lone wolf, which is what everyone is
that is what I personally would really like to drive, the movement from a lone wolf kind of practice to a practice that is really team-based. That's a challenge.
True. It's a challenge kasi nga of our
training. Orientation, yes. But so go ahead with from the molecular to the AI. Health economics in between.
With health economics in between, and the realization that we have limited resources, but there's a huge problem with health, and so we need to gather better data. And the more data you have, robust
data.
It's not just data you pick up from anything, but one that is also well-defined, that is entered into a database that is complete with a clinician entering the data, because our IT friends are very intelligent, but they're not healthcare givers. They're not clinicians. They don't know what it takes, for example, to diagnose pneumonia. So they might be able to say that you can teach an AI how to read an X-ray, an image, and say this is pneumonia. But if a human reader will read it, that reader will say consistent with pneumonia. The reason being, they don't know the clinical. Now, if this particular image patient has fever, has high white white cell count, and has lung findings, then that's the clinical and the sure diagnosis of pneumonia. So that is the contribution of artificial intelligence. We can teach, we can create algorithms that will facilitate the diagnosis of diseases, and that will just make better healthcare. It's not robots. It's not without heart. It's not without mind. In fact, all the heart went to the creation of it. But we also have to be careful, because it's garbage in, garbage out.
Exactly.
So if it's done by someone who simply wants to make money, right? Or who simply wants to be able to make an app that can read pneumonia, kung mali naman, you know, sayang lang. And kawawa naman yung patient.
That's correct.
That's what we're doing here. We are working together.
Which is quite parallel to the digital journey that we're having now at the moment. Yes. So everything is in cadence.
Yes, correct.
Before I ask you the last question, which is basically, how do you see the APSI that you're leading in the next 5 years? Maybe in a way to close it. I just like to bring up the issue that you brought up about the big C, the parallelism between the big C, which is cancer, and the big C now, which is COVID.
Second big C.
Yes.
Well, I looking back since March 2020 up to today, all of us, our lives have changed, and many of us have learned. Some of us don't realize it, and I like the term language, how it has changed our lives.
That's right.
It's like we're caught in front of headlights. We cannot move. We don't know what to do. Right. But from a perspective of a medical oncologist, we have been taking care of patients who have been inflicted with a life-threatening disease through no choice of their own. The same way, in the beginning, COVID just happened. And no one wanted it. But people started dying of it until we realized that it can be prevented. Same with cancer. But that is something that is we still have to get better at. Is making people realize that cancer can be prevented. That's why our focus of APSI, and you were asking me that earlier, is the prevention, public education, and the prevention of cancer, so that the cancers that do not have to happen will not happen. There are some cancers that are indeed unavoidable, and those are the ones that will need institutes like ours.
That's right.
But those that are preventable, if you prevent it, then there will be more room for others who really need hospital care. Same with COVID, right? Yes. So if you can prevent the mild and the moderate, or treat them at home, but keep them out of the hospital, and especially prevent it and treat it early, just be reassuring, just be there for them. So those are the things that I use in my experience as a medical oncologist to help the people around me with COVID who are asking for help to cope with the illness, to cope with the pandemic. So that is, our patients with cancer, they wear masks and they're afraid of infection because they have no immune system.
That's right.
It's the same with COVID, right? They wear masks, but they come to the hospital because they know they need treatment. So our patients who are afraid of COVID, we remind them, especially our cancer patients, but even those without, you will not get the illness if you know how to prevent it. And that's it.
That's it. There you have it. And I think what we have in so short a time, we have not only one perspective, but various perspectives of one person Dr. Beatrice Tiangco, and how happy and proud we are here at the Medical City that she continues to pursue her passion, not only just to lead the Cancer Institute, but also to influence a lot of doctors here in this hospital. We would like to thank Trixie, and more power to you.
Anytime, Eugene.
Okay,
thank you for inviting me.
Thank you.